Hello, this is Dr. Marty Lustig, Principal with NextGen Advisors. Welcome to our podcast series featuring senior leaders from the NextGen Advisors team. I'm joined again today by my partners, Graham Brown and Dr. Betty Rabinowitz. Welcome, Graham and Betty.
Hi, Marty.
Good afternoon, Marty.
Last week, we met with leaders of provider groups from across the country to listen to them talk about their strategic priorities, concerns, and hopes for the future. Over the course of 2 days, we listened to 19 leaders representing over 4,000 providers from 13 different states. We were able to hear from multi-specialty groups, primary care, FQHCs, Planned Parenthood, OBGYN, behavioral health, orthopedics, and neonatology. Today, we'll discuss some of the themes that emerged from those discussions. Betty, I'd like to start off by asking you, since you've now hosted several of these meetings, what was different this year compared to years past?
Thanks, Marty. The first obvious difference was that we met virtually. Our previous listening meetings were in beautiful Southern California, where people had an opportunity to spend time together. It was a 2-day meeting. And something about the personal interactions, personal relationships in a beautiful setting created a wonderful environment for sharing thoughts and strategic kind of opinions. But nonetheless, I thought this year, in spite of it being virtual, that we really had terrific conversations. So virtual was one difference. The other difference obviously was in the content, the mood, because this is an unusual year. The pandemic began just shortly after we met last year in person, considering the fact that there were probably cases in the US in December. So, and I'm sure you will have an opportunity to talk about the different content, but the mood was impacted by that quite significantly.
Thanks. So, as we talk about the mood, Graham, can you share what you heard in terms of the most significant concerns as we asked leaders what was keeping them up at night?
Yeah, sure, Marty. We kind of did this in two parts. So we asked the groups to kind of say in one word, sum up for us what 2020 meant in healthcare. And there were some really fascinating one-word responses to that, which I think very much build on what Betty just said, this year of uncertainty, disruption, urgency, and exhaustion, breakdown but breakthroughs for groups in terms of how they needed to address the challenges they were facing. Countered with that was innovation and inspiration and eye-opening. So there was a real sense, this balance between, it was an incredibly difficult year, but I think folks learned a lot about how they could be resilient, how they could really tap into their team's strengths and move forward. From an uncertainty and kind of concern perspective, financial uncertainty was certainly one of the themes that we heard. Many providers rely on a fee-for-service payment model, and that was very much disrupted by the closures and the inability to serve patients face-to-face. As a result of that, there's been, a real focus on margins and where do some of these groups actually have profitability, and how do they protect against risk and make sure that they're supporting their staff to prevent further burnout or prevent folks leaving, make sure that they can retain those staff and keep them energized and focus on the work ahead, because we're certainly not through the COVID pandemic yet.
Betty, your thoughts on what kept them up?
I really agree with Graham that existential angst in the context of volume decreases was top of mind for folks. I think that telehealth, that became such a huge part of people's workflows early in the pandemic, has brought some angst around, will it continue? Will reimbursement for it continue? What role it plays in their overall strategy. Groups are concerned about staffing. Some staff retired in the context of the pandemic, and will they be able to retain the rest of the staff, support the rest of the staff? And in some areas, it's hard to come by. There's a shortage of nurses. So I think there was some staffing concerns as well that came up.
So I'd like to build on that issue you just raised about staffing, because as we think about what we heard when you talked about staffing and operations, and particularly strategically looking forward, how did the providers talk about the way their strategic view looking forward has been impacted with regards to their staffing and their operations by what's going on this year? Graham, you want to start with that?
Yeah. You know, healthcare, I don't think, was unique in this way, where to the extent that companies could create a model where staff could work from home and could be home-based in a safe environment, not interacting with each other, many healthcare organizations recognized that there were non-clinical, non-patient-facing functions with regard to billing or back-end services that could actually be done by home. So a lot of folks were moved into a home environment and work from home. What that brings now then is kind of a new operational model where the clinics may end up with more physical space than they need. They need different types of systems and management processes to oversee these staff, to ensure that they're working effectively from that environment, that they have the tools and resources they need to do their jobs, but also that those staff members have, the interactions with other team members that keep them sustained, keep them interested in their work, keep them interested and connected to the clinical role. These folks work in healthcare for a reason. They want to feel connected to the patients they're serving and to the clinicians they work with, even if they're not doing frontline clinical work. So I think that's a real challenge for organizations kind of culturally to address now, and think about if we're going to pivot in the long term to have folks not co-located together, what are the implications of that? How do we maintain the organization we want to be, and actually set up then the tools that support that from a technology perspective, from a communications perspective, expectations, performance, etc.
Betty, your thoughts?
I think it gave folks an opportunity to reevaluate some of the areas of activity that they have been traditionally engaged in. And it was the first time I heard several of the leaders talk about focusing on what they're good at and focusing on their core capabilities and shedding lines of business or practice topics that weren't central to who they are and that they didn't necessarily feel were contributing to their identity or success significantly. So getting more focus, getting smaller focus on areas that you're very good at in order to ensure success. So that was something we heard from the leaders quite a bit this time.
Yeah, the one other thing I might add, particularly to what you were saying, Graham, around the work from home issue, we clearly heard a recognition that this more virtual workforce creates both an opportunity and a threat for the providers as they see their staff able to market themselves beyond their local geography if they're going to be able to work from home, at the same time that they can potentially either keep or recruit people who aren't living proximate to where their clinical offices are. So it was interesting to hear them talk about sort of both sides of that coin. Let me move to, you mentioned earlier about the stress financially, particularly for those who were largely in fee-for-service. What did you hear about the impact of the pandemic on how they're thinking about value-based care going forward? Betty, you want to start on this one?
Yeah, it's interesting. We really, I think, felt that there was not anymore a question of whether value-based care would be part of their strategy. There was really a sense that it has almost become a given. It's there, they're tackling it. The element that was highlighted this year was that downside risk is becoming a reality with the MSSP ACOs shortening the range of time where you need to take on downside risk, and some of the commercial plans having downside risk coming due. That's the biggest concern. Groups have completely engaged. There's been advantages to being in capitated arrangements this year because it shielded groups from the fee-for-service decreases, but there is angst around taking on true downside risk. So it was very interesting to see no longer a question of if, but a question of how.
For many organizations on this pathway to risk, getting their heads around what their role as clinicians and managers of the healthcare experience and managers really of patients' complexity means in terms of how they care for patients and how that translates then into the clinical models they put in place, the care management programs, really identifying the sickest or most at risk, and how they outreach and coordinate the care for those folks, ends up having a direct correlation at the end of the day to cost. But there are tools that are needed to create that linkage between quality, outcome, managing those who are sickest, and the preventive care that they need, and linking that to cost. And that's the really big hurdle for provider organizations to get over. They can get their head around the quality measures, they can get their head around documentation, but moving the needle on all of these pieces that ultimately achieves a cost saving is the big challenge of value-based care. And the structures that have been put in place from a contracting perspective have moved providers in that direction. But as Betty's saying, those are all kind of ramping up. And organizations really need to be in this game now if they're going to succeed. And so I think there's that little bit of added pressure to kind of, say to providers, are you really prepared for this? Are you really walking the walk the way that you know you need to be doing on a day-to-day basis to be successful in these arrangements? Because ultimately, there are practices that are going to be left behind if they're not really focusing on this and putting in place the tools and structures amongst their care teams that they need to be successful.
Yeah, I think that's a really important point. The other thing that I think we heard, which was not new, was this. While on the one hand, providers, I think, have learned how to play the game with the quality measures that they have, at least those that we were hearing from last week. There's a fundamental, from a clinical perspective, particularly belief that the measures they're being held accountable for are of limited true value to patients in terms of impacting outcomes, and that they would love to see us able to move towards simpler and more meaningful measures of quality than the ones that have been used up until now. I can switch now back to, we mentioned telehealth, which is something we've been hearing about all year long related to the pandemic. Last week, one of the physicians leaders in the group was quite eloquent, comparing the future of healthcare to examples from other industries that have offered tiered access to their expertise. Can you talk a little bit more about this model and how telemedicine services might fit into it?
Sure. The model that was described, as you say, kind of applies in other industries as well. And think of it as a pyramid shape, wherein at the bottom you've got a broad base, and at that broad base you've got services from a healthcare perspective, which enable folks to do self-care, to get education, to put in place tools about whatever conditions they might have, and to interact with a practice, but in a way that really helps them keep themselves healthy and safe. Above that in the pyramid is less concentrated in terms of the volume that would need to be provided, is asynchronous care, where patients can interact with a practice, get specific direction and advice, ask questions about their concerns, their conditions, the medications they might be having, etc., how to best manage their care, and get feedback and responses from the practice. You move further up the model, and you've got group interactions where patients with similar conditions or comorbidities can collectively interact with a practice. We see this a lot in education for diabetics, for example, in physical therapy when we could all collectively get in a room together. Behavioral health has been using this a great deal. And then above that, the top of the pyramid, it really is the one-on-one interaction between the clinician and the patient. And what parallels this kind of narrowing up the pyramid shape is both the direct time you get to spend with the expert clinician, as well as the assumption within the model that as we pay for care, the more valuable care is that one-on-one interaction, and that there should be an expectation from the consumer's perspective that the closer they get to direct one-on-one care, there will be an associated cost increase.
So this was really an intriguing thought. I think telehealth has raised the question of, it's challenged us to think of the interaction between the provider and the patient in different ways. It's now remote, it's virtual, it can be provided from anywhere across different boundaries and distance. Interestingly, I think, Marty, when we had this conversation, you brought up a point that really resonated with me, that in a capitated environment, when payment is for the management of a cohort of patients, there is strong incentive to create this tiered approach, because there's a large population, you can care for a larger population of patients this way and provide the needs without the consideration that the only way you'll get paid for contact with them is by seeing them one-on-one, which has been the traditional model in healthcare now. So it almost is, we're opening a new horizon that says not every interaction needs to be the same model, a patient physically in an office, seeing a provider in a room for X amount of time, leaving with instructions and so forth. It also utilizes technology and contemporary technology in wonderful ways. The richness of interactive apps and automated nudges and building cohorts of patients who can be batch sent materials and information about their illness, the ability to use patient-derived data to drive some of those interactions. It's to me a fascinating approach to now say, okay, we've separated from this singular view of what an interaction is between a provider and a patient. How do we now create a new universe of this that has this tiered approach that is more cost effective, can reach more people, and is not driven by this total need to churn patients in and out because that's how we get paid?
Yeah, and we heard that very clearly from the provider groups that, they've got all these ideas for how they could do it better, but it all hinges on how they get paid.
Yeah.
It's an interesting and huge challenge in the immediate future. It would be a shame to see the innovation that's occurred over the last year go away because of the payment models don't.
Absolutely.
If I can go to a last question and just give me your quick thoughts on what you heard from the providers as they're reprioritizing their strategic investments in light of recent events. What struck you as the greatest areas of need from them? Graham, you want to go first?
Sure. There was an interesting statement that one of the providers made. It's a game changer if you do it, and it's a game changer not to do it. And what this provider was talking about was the facilitation of the relationship between the patient and the practice, and that there needed to be technology investments for them to the point that Betty was just making around this pyramid model, right? And this kind of hierarchy of face-to-face or indirect care. How do you invest in the structure and the capabilities that really enable that across your practice? So that you can indeed take on more patients, serve more, particularly for specialties. So that was certainly an area we heard about. Interoperability was really, key in terms of additional investments in technology and getting the greatest use and greatest utility out of data that's available out there, really turning it into information that supports the practice to effectively serve their patients and make decisions. And then I think there is an ongoing recognition that investments in telemedicine and telehealth will continue, but those need to be balanced with the shift of the practice model over time. That it's not just a technology solution. There's a lot of workflow implications. There's staffing implications. There's role, responsibility, training, and knowledge elements that need to be accommodated into that. So some of these investments really are a longer term play in shifting the care model through a disruptive time and recognizing that it needs to really set the foundations for the future.
Thanks, Betty. You want to add anything?
So my sense was, even though they didn't specifically say this, that the concern that we heard around taking on risk is going to end up being an area where investment is going to be needed both on the side of the practices to gain the expertise, the internal wisdom, and the proficiency to be able to live in a risk-laden environment. And it's going to take, it's a far cry from just massaging some quality measures and doing well in a year financially from a budget perspective, but not knowing exactly what was successful, which we hear from a lot of groups. It's a far cry to managing a given budget and succeeding against it and reducing costs and unwarranted variation to get there. So I think that's one area. And the other area is that there's going to have to be a sophistication level of the technology that supports that is going to be both a challenge for the technology companies like ours to support the needs of a group at risk that are very different than just supporting upside risk and measuring quality in the way we measure it now. So what's exciting to me is that we are reasonably well positioned to support a lot of those needs, but there's a lot of work remaining on both sides.
Absolutely. Well, thank you. Thank you to our listeners for joining us today. And I'd like to thank my colleagues, Dr. Betty Rabinowitz and Graham Brown, for sharing your insights. If you enjoyed today's topic, consider subscribing to our podcast. This is Dr. Marty Lustig with NextGen Healthcare. Have a great day.